Today with us, Dr. Aparna Bole. She is the Medical Director of Community Integration at Rainbow and Babies Children's Hospital and an Associate Professor of Pediatrics at Case Western Reserve University School of Medicine in Cleveland, Ohio. She leads efforts to build close partnerships with community organizations and stakeholders to enhance the well-being of parents, patients, and families at Rainbow Babies and Children's and McDonald Women's Hospitals. She supports innovation in women's and pediatric primary care delivery. She's particularly interested in the intersection between environmental sustainability and pediatric public health. She is the current chair of the American Academy of Pediatrics Council on Environmental Health, where I've gotten to know her a little bit. And she is on the board of Healthcare Without Harm as the co-chair currently. She's a founding advisory council member of the Ohio Clinicians for Climate Action. Dr. Bole, thank you so much for being here today and lending us your time in this busy coronavirus season.
Thank you. Thanks for the introduction, Becca, and for including me in this wonderful course. I'm really excited to talk with you all today about the state of sustainability in the healthcare sector. And what I'm hoping is that at the end of this discussion, you really leave feeling empowered and hopeful about the impact that we can have in our places of work as health professionals in acting on climate. I'll start by saying I have no financial conflict of interest, but I will be referring quite a bit to resources from the sister organizations Healthcare Without Harm and Practice Green Health, and I serve as co-chair of the board of those organizations. Just briefly, the Healthcare Without Harm is an international organization dedicated to advancing environmental sustainability in the health sector and to leverage the health sector's position of leadership to advance environmental sustainability, environmental health and justice here in the United States and around the world. I'm hoping by the end of this talk, you will be able to describe the health sector's contribution to climate change, explain our opportunities for climate action and leadership, and give some real examples of opportunities for physicians and for medical trainees to get involved. Healthcare Without Harm recently published a report quantifying the climate footprint of the healthcare sector globally, and it's pretty staggering. If the global healthcare sector were a country, we would be the 5th largest greenhouse gas emitter on the planet. And specifically, the US healthcare sector has a big piece of that. The US healthcare sector represents about 10% of US greenhouse gas emissions. And if the US healthcare sector alone were a country, it would rank among the top emitters in the world. You can kind of see that this graphic shows the relative contribution of different countries' health sectors to the global health sector climate footprint. And you can see that the United States is top of that list, even though we're not top of the list of emitters as ranking of countries. So our healthcare sector really contributes an outsized share of the global healthcare sector's climate footprint. I'm going to pause here and try asking you a question that I'm hoping you'll respond to in the chat box. If you were going to start naming some of the big ticket items in healthcare operations that contribute to our climate footprint, what would they be? What are the aspects of healthcare operations that come to mind for you as big contributors to our climate footprint? I have my chat box pulled up and I'm hoping that some of you will offer some ideas. Supply chain, single-use materials, waste, energy consumption. I see waste again, energy, cooling, disposable PPE, anesthesia waste, cooling, water usage, medicines and pharmaceuticals. Thank you, that's a really good list. Packaging. All right, I'm going to move on and talk about some of those. Okay, let me change my view here. Okay, here. Okay. Oop. So much of what you said is outlined here. Energy use, cooling, lighting, water, waste, transportation, special mention of anesthetic gases. So we can talk about that a little bit more as well. Purchasing in general, but food purchasing in particular, transportation of supplies, our buildings themselves. So these are some of the bigger ticket items that contribute to our operations climate impact. And I think a way to simplify that is shown here. So when we think about our individual climate footprint, it's really all about where we live, how we get around, and what we eat. So sort of similar in healthcare, buildings, transportation, purchasing, and I think food purchasing deserves special mention. So I will talk about that. And I'm going to talk about them sort of in that order. I'm going to talk about energy first, transportation, and then purchasing, especially food purchasing. And one of the things I'm going to try to do as I go through, I think one of the barriers for some of us as physicians in getting involved in advocacy related to environmentally responsible healthcare operations is that we kind of lack the vocabulary to do that. And we're not always sure like who to talk to and how to ask the question, and just how do we insert ourselves as advocates in this space. So what I'm going to try to do with some of the following slides with some of the topics that I think are kind of highest impact for us is to have like a little red box where I'm going to put some questions that help us with a script or sort of a vocabulary to get involved around some of these topics. So starting with energy, and once I get through energy, transportation, and purchasing, I'm going to mention a few other special topics, including waste, pharmaceuticals, and some of the other things you all mentioned. So starting with energy, I'm often asked, less frequently now, but still get asked why a pediatrician is so interested in her hospital's energy consumption. And so I like to frame that advocacy by pointing out that our energy use directly impacts the patients that we serve. This graphic shows hotspots for morbidity and mortality due to particulate air pollution from coal-fired power plants. And I'm located right up here in Northeast Ohio, in Cleveland, and you can see, so the darker brown indicates higher rates of morbidity and mortality from coal-fired power plant pollution. So we're right in the middle of a hot spot. So I try to make sure people understand that the reason I care about our energy efficiency is because it directly relates to the quality of the air that my patients are breathing. And so to explain a little bit more about our energy consumption in healthcare, we are the second most energy intensive sector in the United States. We consume 10% of the energy used in US commercial buildings. We spend billions of dollars a year on energy. And the EPA, if you look at EPA estimates of healthcare or health effects of air pollution that's attributable to energy consumption, the healthcare sector in the United States, energy use can be related to $600 million a year in healthcare costs related to the increased respiratory burden that our energy consumption causes. Kind of a way to wrap our heads around these really big numbers of energy use. How does that really relate to patient health? Energy efficiency saves operating costs in healthcare, just like it does in every industry. In the United States, about 40% of commercial buildings' energy is just wasted. And hospitals are no exception. There are some pretty simple interventions to increase energy efficiency that have a huge and quick return on investment. This is a series of case studies that the Commonwealth Fund looked at to quantify the return on investment of some of these energy efficiency interventions. And in an environment where we're constantly trying to increase our razor thin operating margins, and we're making tough decisions about staffing and nursing and overhead, and now we're experiencing this time of financial stress in healthcare, energy efficiency is a way to make a minimal upfront investment a lot of the time that doesn't affect nursing or staffing or patient care, and realize a really quick return on investment. So here's my little red box of some questions that I would ask if I were an employed physician wanting to ask my hospital leadership about our energy efficiency goals. And these can be kind of adapted for practice management too in an outpatient setting. But what's our energy efficiency goal? Do we have an Energy Star score? If not, why not? Have we undertaken some common energy efficiency measures? And here's some that are applicable in healthcare. Retrocommissioning, which refers to seeing how well our energy systems are really functioning, and are there problems with our settings or our switches or the way that our machinery is functioning that's causing us to waste energy. That's very easy to fix and has a very quick return on investment a lot of the time. Lighting retrofits, computer power management. So how do we manage computers that are not in use? Are there behavior changes that we can be advancing to make sure that we're addressing thermostat use and light use and some of the other things that are impacted by employee behaviors. Are there OR energy efficiency measures that we've implemented? And I'll talk specifically about operating rooms in just a little bit because it's worth delving into that in a little bit more detail. Do we have a green building policy that specifies goals for energy performance? So those are some scripted questions that I think are high yield in most healthcare environments. A growing number of health systems are committing to energy efficiency and renewable energy goals, and this represents an opportunity to collaborate and do some friendly competition with some of our peers. So the global challenge is called the Healthcare Climate Challenge, and includes both, as I mentioned, efficiency goals, which is number one of the list of interventions I would recommend in healthcare, but also renewable energy goals. So there are multiple institutions in the United States and around the world now that have committed to transitioning to 100% renewable energy. And we say that the prescription for better health is transitioning to 100% clean energy. And that includes on-site solar, geothermal units, wind energy, investment in renewable energy in our grids, so sourcing from our utilities from renewable energy. I'll give you an example of some on-site solar projects in my own institution. There's a children's hospital in Dayton, Ohio that did a geothermal retrofit that's been really effective. Gunderson Lutheran is an example of a hospital in the Midwest in Wisconsin that has had really ambitious in energy independence and renewable energy goals, and they have some great wind projects. So there are examples of these here in the United States and around the world. And I'll talk a little bit more about collaboration between health systems and some of these commitments to transition to clean energy in a little bit. Shifting to transportation, this is a part of our carbon footprint in healthcare that I think is too often overlooked. This graphic, it reminds us that if we have incentives and programs in place that provide incentives for people to get to work in ways other than single occupant car commuting, people take advantage of those options. And also, whether if you're taking public transit, there are wellness benefits of doing that. People who take public transit tend to walk more than people who don't. Of course, walking and biking have active transportation benefits as well. So there are examples of healthcare systems that have commuting incentives for employees, either wellness points that give you discounts on your health insurance, or free public transit passes, which is something that we do in our institution. So the questions to ask might be of your employer, what kind of incentives do we have for commuting via public transit, walking, biking, or carpooling? We also have a program in my institution, and many others have this too, that provide incentives for employees to live near where they work. So we have sort of a financial incentive for employees to seek housing near our main campus. And then maybe flexible parking options for those who can use alternatives to single car commuting sometimes. So for example, I bike to work most days, but if there's that day that I have to like drive and pick up my kids and go to a dentist appointment or something, I have a free flexible parking pass that I can use for those days. So when institutions have those programs in place, they really work. And what I'll mention in addition to commuting is we also can be thinking about fuel efficiency of our fleet vehicles and more efficient routes for our health system fleets. So things like courier services and lab deliveries and those kinds of things. And I'll say too that where we build our facilities has an important impact on our transportation footprint and on our climate footprint. So I won't be able to dive into this in too much detail, but the bottom line is when we have a fee-for-service healthcare system that incentivizes going out and seeking more revenue further and further out into suburbs and exurbs, and we have a lot of duplication sometimes of those services. So in a competitive healthcare environment like mine in Cleveland, multiple sort of identical ambulatory megaplexes further and further out from Cleveland, that has a huge climate impact. And so just kind of thinking about where we build and why we build that way and how our healthcare system incentivizes us to do that is an important part of our conversation about our climate footprint and our transportation footprint. So the location of our buildings, and you know, we can install as many solar panels and windmills as we want on those new buildings, but the more we have this overbuilt medical system that doesn't always meet the needs of the patients we serve, that's a problem too. So I'll talk a little bit about supply chain. Supply chain is a huge part of healthcare expense. And we have huge purchasing power in healthcare. So there are many examples of health systems that have built environmental considerations into their purchasing practices, including climate considerations, but others too. So we've worked on things like less toxic cleaning, non-disinfectant cleaners, and a lot of healthcare without harm member hospitals, and that's been very effective. So supply chain, lots of opportunities there. I'm going to delve in particular into food purchasing because I think it's an arena that that really connects well to our health message as physicians. And it's been an area that physicians, I think, have been very successful in advocacy. Red meat purchasing actually represents a huge proportion of our purchasing footprint, environmental footprint in healthcare. And I know we don't use the food pyramid very much anymore, but I like this graphic because it emphasizes the fact that the kinds of foods that we want to be eating more, and we want our patients to be eating more, whole grains, whole foods, fruits and vegetables, tend to have less of an environmental footprint to produce than some of the foods we probably should be eating less of, including red meat. And Americans eat a lot more red meat than people around the world, and a lot more than we should in a lot of cases. So it's kind of a win-win-win if we can create some goals around healthier food purchasing that include reducing our red meat options on our menus. So one of the things that we did in our institution is created a nutrition committee with clinicians represented. I think a lot of clinicians complain about hospital food, but we don't often feel we're empowered to make a difference in what the offerings are. We created a nutrition committee and had some quantitative goals around decreasing our meat purchasing, which included like redesigning some of our menus, and some local purchasing goals as well. This is sort of out of scope for a talk on climate, but I mentioned that antibiotic stewardship in meat production can also be part of your food purchasing goals and fits in really well with the sort of global antibiotic stewardship programs in many of our institutions. So that was part of our work too. And here's a link to something called the Cool Food Pledge on the Healthcare Without Harm website that, that health systems can sign up for in order to have some ideas about goals in designing more climate smart menus and healthier menus too. I'm not going to say too much about waste, except to say that health systems are huge generators of waste. I wanted to really focus on energy, transportation, and purchasing, but I'll mention waste for a few reasons. Number one, the disposal of certain kinds of medical waste is very energy intensive. So red bag waste, infectious or hazardous waste can be very energy intensive, and food waste is a big source of climate impact as well. And so there are some opportunities here that I think are important to keep in mind. And the other thing I'll say about waste management is it's often a very visible way to engage employees and providers in environmental stewardship initiatives. And actually waste management efforts is how I got involved in sustainability in my institution's healthcare operations. So I think I'll talk a little bit more about that in a bit, but lots of different waste streams in healthcare. It's important to keep in mind that in terms of solid waste and organic waste, we're no different than any other organization typically. So we have some of the same opportunities to reduce solid waste, increase recycling, decrease food waste, manage food waste better. I think a lot of people get very hung up on the fact that we have all these special waste streams in healthcare, and that's true. We have some big opportunities to reduce our environmental impact there, but we can learn from other sectors when it comes to managing solid waste and food waste. I want to talk a little bit about greening the OR, which is a specific program within Practice Green Health and a principle that's worth understanding because the operating rooms contribute just an outside amount to both our revenue, our expenditures, and our environmental footprint in healthcare. They produce a huge amount of facilities waste as well, and they consume a tremendous amount of energy. There are a number of opportunities for greening the OR that I think it's important for those of us who plan to work in that space to know about. Somebody mentioned anesthetic drugs as one example. Here's one of my little red boxes, so a couple little pearls. The choice of anesthetic gas makes a difference in the greenhouse gas impact of an OR's operations. So there are some good examples of anesthesiologists who are real leaders in educating their peers about this. So for example, desflurane is 20 times as potent of a greenhouse gas as sevoflurane. So being really mindful about why we're making those choices and being aware that there's a real difference in environmental impact is pretty substantial. On a similar note, some efforts in anesthesia around waste anesthetic gas capture rather than just venting those waste gases. HVA setback refers to what happens in the operating room when it's not being used. So there are rules around high ventilation rates in hospital operating rooms, and you can imagine that's very energy intensive to do air exchanges where you're constantly having to heat and cool that air that's coming in and ventilating that space. So when the operating room isn't being used, it's a huge waste to continue those air exchanges. Similarly, like, can the temperature drift when the operating room is not in use? So those efforts can save a ton of money and reduce our climate impact in the OR significantly. A lot of places now have done LED surgical lighting retrofits, but there's still some that haven't, and so I'll mention that too. It's a win-win-win to do this because the LED lights are higher quality and give off much less waste heat. So it's much more comfortable for the surgeon and staff in the operating rooms. And they tend to pay back over the lifetime of their use because they're significantly less energy intensive. And then waste management is a big deal in operating rooms as well. Oh. Again, water is one I'm not going to talk about as much, but I do want to mention that even in a water-rich region like mine, water saving is important because water saving in healthcare is energy saving. There's energy required to distribute heat and chill that water. And we use a ton of water in healthcare from all of our fixtures, but also for laundry and sterilization and landscaping. So it's an important area, and I'm not gonna have time to dive into it too much. But I think it's important to keep in mind that our energy intensiveness is related to our water use. Again, pharmaceuticals is another one where I'm not going to be able to talk about it in great detail, but our pharmaceutical footprint in terms of the environment relates both to manufacture and distribution, but also to packaging and disposal. I want to point out that disposal of pharmaceutical waste is incredibly energy intensive, and physicians have a big role to play in limiting pharmaceutical waste. I can talk about some specific examples later on if you guys would like. But it's another important contributor to our overall environmental footprint, and one that we sometimes as providers can have a big role in making some changes here. I want to talk a little bit about climate resilience too. These are some images of what can happen to healthcare facilities in climate-related disasters, including post-hurricanes, during wildfires. This is evacuation following Superstorm Sandy of a hospital that lost power. And I think we're thinking a lot about resilience right now as we're experiencing this COVID-19 pandemic and thinking about what it means to be prepared. So there's some real opportunities for us to build in climate resilience. When we talk about climate smart healthcare, it's about our contribution to climate change and also our preparedness to serve our patients when we need them. So specifically, this the screenshot here is of a report on climate resilience. The link is on the lower right there. That includes some case studies about how health systems have effectively prepared for climate resilience. There's examples from around the country. And some specific things that I put in my little red box here to ask might be, how are disaster preparedness plans incorporating forecasts about climate change impacts? How are we incorporating that into our preparedness infrastructure in our health system? What does supply chain resilience look like in a changing climate? And this one is kind of interesting because there have been some questions that have come up around resilience related to supply chain during the current pandemic in our access to PPE or lack thereof. I'll just share kind of an interesting anecdote. I recently lost a battle in my own health system that I had been fighting every couple years in that they decided to switch from reusable to disposable gowns a few years ago. And one of the challenges with collecting reusable gowns in a lot of systems is that there are JCO limits on where you can put how close together you can put bins of different kinds, collection bins, on patient floors. And our infection control folks said, it's too hard for us to have the bins for reusable gowns. We're gonna have to switch to disposable gowns. And in this moment where access to gowns and other PPE is an issue, we have a local laundry. We're in a water-rich region. From the standpoint of reliable supply of gowns, maybe we need to reconsider how can we make it possible for reusable gowns to be used. And from a life cycle perspective, it's definitely less impactful on the environment in our region to use reusable gowns. So just kind of a different, building resilience into our thinking about sourcing of supplies, I think is really important. And then I put on here, investing in community resilience is something that we can do in healthcare as well, and I'll explain a little bit what I mean by that. Some of you may have heard the term anchor institution used to describe health systems or healthcare facilities. And so just to explain quickly what that means, an anchor institution is a large employer and purchaser that is anchored in a particular community, like it's not going anywhere. Healthcare facilities, hospitals, tend to be anchor institutions in their communities. They're large employers, they're large purchasers. We're not going anywhere. We're rooted in our city. And often people talk about eds and meds because other anchor institutions often include universities. Here in Cleveland, our network of anchor institutions that works together includes university, health systems, and also city government. This network of healthcare anchor institutions is something that's been convened by the Democracy Collaborative. It's pretty interesting. If you want to check out this network, it is evidence that there's a growing number of health systems around the country that are really interested in leaning into their role as anchor institutions and advancing community health and well-being. I'll give you an example of how this is played out in Cleveland. And this is an arena where I think we as physicians have a really important role to play to center public health in the mission of leaning into our anchor institution role. So here in Cleveland, in the mid-2000s, 2004, 2005, we were brought together, anchor institutions in Cleveland were brought together under this call to action. So just like many other cities, in Cleveland, some of our most economically disadvantaged, historically redlined neighborhoods that were disinvested through racist housing policies over the decades, these neighborhoods that have some of the worst health outcomes in the city surround our health institutions and some of our cultural institutions. So we're like right smack in the middle, our health system and our university medical school, right smack in the middle of communities that have suffered from incredible environmental injustice and economic injustice over the years, and their health outcomes are evidence of that. So our CEOs came together around this call to action. This is the median household income of this neighborhood called Great University Circle that surrounds our hospitals. It has very high unemployment, and whatever health outcome we look at, I have infant mortality on here. High rates of infant mortality, poor health outcomes where the racial disparities are really just criminal. So this was sort of the lay of the land in Great University Circle in the mid-2000s. And in Great University Circle, we have major institutions that include museums, cultural organizations, hospitals, university, lots of jobs, a high proportion of all the jobs in our county. Cleveland Clinic and University Hospitals, which is my institution, are the largest employers in the county and some of the largest employers in the state. In the mid-2000s, we were all planning these big building projects, new hospitals, new emergency rooms, new university buildings. $3 billion in development was being planned. And so our city foundation convened our anchor institutions, in this case, University Hospitals, Cleveland Clinic, Case Western Reserve University, and the city of Cleveland, to create what they called the Greater University Circle Initiative, which we affectionately call Gucci sometimes. And the question that they posed was, how can we leverage the economic power of our institutions and this huge amount of development dollars that we were about to invest to build inclusive wealth and healthy neighborhoods in Greater University Circle. And so we conceptualized the work by focusing on how we can live local, hire local, and buy local. How do we spend those dollars locally in a way that advances equity and wealth, sustainable wealth building in Greater University Circle? And we really have been working on that for years. And what's been required is a sustained culture change in our organization, so that it's not just about doing right by the community because it's the right thing to do, it's also the right thing to do for our own institutions and for our healthcare mission. And building environmental sustainability and sustainable development into these efforts has sort of been foundational. So I think that this shift in thinking about how we operate and who we are is really important in our thinking about climate action. And it also relates to, I think, a shift in thinking about what our job is as healthcare providers. You know, that are we just about the 15 minutes we spend in a clinic room with our patients? Increasingly, we hear people talking about addressing social determinants of health and population health issues. And so we need to be turning our attention to what's happening outside the walls of our clinic. So from this kind of episodic medical service to really investing in total health care. And it's really important to us in primary care, if we want to have a real impact on our patients, to make that shift in thinking. And I feel like it's really parallel to this shift in thinking about who we are as anchor institutions. Are we a castle on the hill like this? We're an ivory tower that people come to and then leave? Or are we going to leverage our operational dollars and the way that we practice to be more of an integrated, a community integrated anchor institution that is benefiting the well-being of the people that we serve, both within our clinic rooms, but definitely beyond. And I think that's an important part of our ability to practice climate smart healthcare. So for every problem that we cited in one of my earlier slides about how healthcare contributes to climate change, there's an opportunity, whether it's greening the OR or investing in more sustainable and healthy food purchasing. We have a huge platform to educate and advocate to. Transportation initiatives, we talked about climate resilience, energy efficiency, thinking about our building practices, our landscaping, a lot of different opportunities for us to make a difference. And all of these, there is definitely a role to play for physicians and health professionals. I'll just mention, I said before that there's a growing number of health systems that have a stated commitment to energy efficiency and clean energy. This group is called the Healthcare Climate Council, and they're part of Healthcare Without Harm. These are major health systems around the country that have committed to climate leadership and have made commitments to renewable energy and energy efficiency in their own systems. They represent hospitals and health systems all over the country from 36 states and represent a huge number of patients served, employees, and billions of dollars, hundreds of billions of dollars in operating revenue. I really like this reminder that in healthcare, our healing is part of our mission. And we also have this incredible platform with our economic power to use our economic and our ethical platform and our influence to create ecologically sustainable, equitable, and healthy communities. And I would argue that physicians and other health professionals should really be at the heart of transforming healthcare to live out our mission in this kind of way. So I tried to give you some kind of scripted questions and language that might help start that conversation wherever you're employed or wherever you practice. I like to remind ourselves too that the decisions that physicians make account for a huge proportion of every healthcare dollar that's spent, whether it's our supplies, our medicines, our choices about how we operate. We can have a real impact on climate change in those choices at the bedside, and because we have power with our leadership because of who we are and how we drive sort of our healthcare institutions' mission and operations. I want to share with you kind of a real life example of that. I think I want to make sure that people understand that as medical students, as residents, you have a huge opportunity to make a difference. I actually got started in my healthcare sustainability work when I was a medical student, and I continued it as a resident. And I can tell you that I didn't always feel like I was welcomed with open arms from healthcare administrators. I was definitely kind of learning as I went. I had to knock on a lot of doors. And actually my senior year of residency, I had been asking a lot of questions about waste management in our hospital and questioning why there didn't seem to be a strategy around decreasing waste. And as I mentioned, this is such a visible opportunity to live out your values and also to engage employees in environmental stewardship. So my senior year of residency, my senior research project, I did a waste audit, and I actually rented a dump truck and got permission to collect both regular waste and red bag waste. The red bag waste I sorted on site. The solid waste I collected in this dump truck and sorted through it and weighed it, and tried to determine for the solid waste how much recyclable waste or avoidable waste are we throwing away, how much organic waste are we throwing away. And in the red bags, I wanted to know how much of the material in the red bags were really red bag waste, really regulated medical waste, and how much was just thrown in there because it was convenient and it really didn't belong there. And to make a long story short, it turned out we were throwing a ton of dollars in the trash. I mean, we were throwing away into the landfill material that didn't need to go in the landfill that we may have been able to earn rebates on. We were throwing away things that shouldn't have been thrown away in the first place that we were then going to have to buy again. And then with red bags, I found that upwards of 85% of the waste in the red bags was just regular medical waste, and it costs at least 3 times as much to dispose of the red bag waste once it's in there. And so the dollars were pretty compelling, and that's how I was able to make a business case with our leadership to start a sustainability office. And it came from a senior research project during my residency. And then more recently, I was involved in designing and building this ambulatory center that is in a part of Cleveland called Midtown, which is really on the margins of our Greater University Circle footprint, so really squarely in the footprint of the neighborhoods that I mentioned before that have suffered so much discrimination and poor health outcomes. And this is where our new Rainbow Center for Women and Children is located. It's the location for our pediatric resident practice. So this is our academic pediatric primary care practice, and it's also the outpatient academic practice for OBGYN. And I was part of the design committee as sort of like one of the people practicing there, kind of like an owner's representative with all the designers and stuff like that. And it was really important to me that we make this the greenest and most sustainable building that we could. And so the location was the first part, but then I, honest to goodness, was sort of like YouTubing videos about how the language of passive solar design and energy efficiency in building. I mean, I'm not a building expert, I'm a physician, but I really tried to just develop a script for myself so that I could insert myself into these conversations about energy performance and green building. And it really made a difference to have the team of physicians united in those values and be able to really press them, because our building is now a USGBC LEED Platinum certified building. There are not that many of those in healthcare. We have exceptional energy performance. We have solar panels that were installed by local workers who are part of a worker-owned cooperative called Evergreen Cooperatives that's dedicated to wealth building in the same neighborhood. Our solar panels generate about 50% of our building's energy use, which is pretty phenomenal. We have outstanding stormwater management infrastructure in this campus, which is also really important in our region. We have really strict indoor air quality standards around indoor materials and cleaning products. So I think it's pretty wonderful to have one of the greenest and healthiest buildings around, serving patients and families who have been on the receiving end of so much environmental injustice. And that really was from physician advocacy on our team. So I just want you guys to know what a difference you really can make, whatever your role might be, as medical students, as residents, and beyond. I'm going to offer you a few resources here that you should know about if you want to get more engaged and continue to learn. Some of them you may have heard about before. I'm guessing that you've either heard about or others have mentioned the Medical Society Consortium on Climate and Health, which is a consortium of medical professional societies who have joined together to sort of speak as one on the importance of acting on climate for the sake of our public health. I'll mention a few specific resources that relate to healthcare sustainability in particular. Many of our medical professional societies have policy statements and position papers now on climate change and health. This one is from the American College of Physicians. And what I like about it is that it has a toolkit that goes with it that includes some specific action items for physicians that can help us make a difference on sustainability in our medical practice and in hospitals. Healthcare Without Harm has a growing physician network, so a growing network of docs who really care about environmental sustainability in healthcare, and we learn from one another. The physician who leads this here, Dr. Amy Collins, is an emergency medicine physician in Massachusetts, and she has coordinated this network of physicians who are really engaged in advancing this work all over the country. here's a link here. And then for medical students, there's a growing organization called Medical Students for a Sustainable Future, which you can see some information about them here. Medical students across the country dedicated to climate action and advancing climate smart healthcare. There's some contact information here too at the bottom if you're interested in learning more and getting involved. I'm going to conclude with this video here, if I can get it to play. This is a video from Healthcare Without Harm. It's a little bit out of date now in that it cites statistics about the US healthcare sector's greenhouse gas emissions. It says that we represent 8% of the total US greenhouse gas emissions. We're up to 10 at least now. So unfortunately, we're kind of moving in the wrong direction there. This is a little animated short. The animated figure is me and the voice is mine. But it was definitely a team effort to produce, and I was grateful to play a small role in it because this really is an authentic, I think, expression of my feelings about what our opportunity is in advancing health sector sustainability.
Like most doctors, I began my career by swearing my allegiance to the Hippocratic Oath. As a pediatrician, I was so proud to be part of the tradition of the ancient doctors who swore, in the same spirit as we do today, to treat the sick and protect them from injustice, and above all, to first do no harm. Since the times of Hippocrates, medicine has evolved in unimaginable ways. Inside our clinics, we've become brilliant at treating our patients' symptoms. But outside our walls, some of these illnesses are growing to epidemic proportions. Of course, we ask ourselves, what is making people sick in the first place? And why do they keep coming back? In our journey to diagnose and treat the body, we've been to the moon and back many times over, masters and explorers of the very small. But 20 years ago, some of us saw that to understand the problem, we had to take a wider view. From that vantage point, we saw thermometers, each containing enough mercury to poison an entire lake, piled up in our trash. From an even wider lens, we saw medical waste incinerators on our own properties throwing toxic fumes skyward. Dioxins and mercury from waste incineration fell to earth, entering the water we drink and the fish and animals we eat, poisoning our bodies and the developing brains of our children. Our own fingerprints were all over the scene. We were contributing to making our own patients sick, all in direct violation of the oath we had sworn to do no harm. So we formed a coalition of doctors, nurses, and advocates to push back, and pushed healthcare to stand with our oath and clean up our own house. Today, only a handful of incinerators exist in the US, and mercury thermometers are going the way of the horse and buggy all around the world. But while you listen to me, the climate is changing, and the people we serve face perhaps the biggest harm of all. Now we need healthcare to be a leader within this widest scope. Look at healthcare's global footprint. We consume huge amounts of energy on every continent, contributing to climate change and air pollution that kills 7 million people a year. In the US alone, healthcare is responsible for 8% of greenhouse gas emissions. But here's our leverage. We are 18% of the US economy and 10% of the entire global economy. The changes we make really can move entire industries away from harm and set new norms that will positively impact our patients' health. Imagine, for instance, if healthcare fought antibiotic resistance by purchasing only antibiotic-free meat, or how innovative solutions to eliminating waste, like biodigestion, could help power hospitals and reduce air pollution around the world. Healthcare could help make renewable energy viable. By choosing to turn away from fossil fuel, we would reduce the carbon emissions that harm our patients and our planet. We stand at a turning point in the course of medical history, and we can move to a tipping point. It's within our power and our mission. Dr. Martin Luther King said the moral arc of the universe bends toward justice. Join us as healthcare bends toward a more just and sustainable future, rooted in our original oath, do no harm.
I'd just like to conclude by acknowledging some of the people who helped very much with putting this presentation together. Jessica Wolf, who's the Healthcare Without Harm Director of Climate and Health in the United States, and Dr. Collins, the Director of the Physician Network for Healthcare Without Harm, were both very generous in sharing slides with me. I welcome you to contact me anytime. And I'll just mention, the reason I put these pictures on my last slide, I like to just conclude with another hopeful note, which is, here in Cleveland, we're sort of infamous for some environmental disasters in our past. Our river, the Cuyahoga River, is famously pictured on the cover of Time in 1969 because it was on fire. Dr. Seuss was inspired to write the Lorax, partly because of how dirty Lake Erie was at the time. The original line for this page was that the humming fish are in search of water that isn't so smeary. We hear things are just as bad up in Lake Erie. He changed the lines when Lake Erie was cleaned up. But I really, even though those are sometimes cited as shameful marks in the history of the Great Lakes and of Northeast Ohio, I really regard those as examples of our being canaries in the coal mine that led to the birth of the modern environmental movement 50 years ago now. This is what our Lake Erie Beach looks like now in Cleveland. It's really a jewel of our city, a far cry from the days of Dr. Seuss. And so now I think it's just a perfect time. We're looking at the 50th year of Earth Day, of Earth Month, the 50th anniversary of the birth of the modern environmental movement. And I feel like we in healthcare have such an opportunity to lead the way for the next 50 years and beyond. So I'll stop there and I welcome your questions.
Thank you so much, Aparna. That was wonderful. I had not seen your full short video and really appreciated the chance to view it alongside the students today. And thank you as well for bringing up Med Students for a Sustainable Future. That group has been really supportive of this effort. I know several of the folks on the call are members, and if not, you all should check it out and join. And I really embrace that need that you expressed to transition from our model of episodic care towards one of total care, of care that's integrated within the community from our anchor institutions. And I challenge you all, as you are gearing back up over the next months for clinical rotations, what do you see? What are the opportunities you see to get us towards that goal that Dr. Bole mentioned there? While Claire is gathering our questions, I have one for you that you touched on a little bit and want to know your thoughts. I have certainly seen with coronavirus this tension, as you mentioned, with the example of reusable gowns, between infection control and supply chain. We both have some supply chain vulnerabilities as we're seeking disposable products, but we also have this issue of concern about reusable products with infection control as we're addressing this infection and this risk in front of us. What are some ways that you think we can bridge those two challenges of infection control and supply chain resilience? Any thoughts there of strategies you're seeing that are effective?
Yeah, I know this is a rapidly evolving area of interest in the context of the coronavirus response, but you're right. There's a much broader conversation that's been going on for a long time, and a tension that I don't think needs to be quite as tense as it is. I think number one I think really important opportunity is more research and study and readily available data about what constitutes safety. I think there are assumptions made about the greater safety of single-use disposable items that when studied don't really bear up. So there are some really good studies on reprocessing of single-use items in operating rooms that demonstrate at least equal, if not more, safe standards for the reprocessed items, which may not be intuitive to people who kind of grew up in that post like 1980s transition from more reusable to disposable items. So I think number one, data to help dispel some assumptions about single use always being the safer option. Some of us have seen this kind of debate play out with, say, laryngoscopes and speculums and things that they don't even, this is sort of pre-coronavirus. I think that's one issue. And I think that the point about resilience, building the resilience piece into our planning for purchase of these supplies is incredibly important. So as I think back to the debates that ultimately I lost around reusable gowns in my system, I don't think we did enough to think about resilience. And maybe we could have fought a little harder against what we thought were immutable JCO requirements around these bins, because there are some hospitals hospitals who have figured that out. And I think if we had been maybe a little bit more inclusive of resiliency considerations, instead of just like, it's hard to find space for the bins and we may as well switch to disposables. And from a cost standpoint, it was sort of neutral. I think that was a missed opportunity. So I think thinking about resilience, really relying on data instead of assumptions about single-use devices being safer. And I think now we're also seeing some of the downside of not having that data, and out of necessity, we're seeing examples of reuse and reprocessing of some single-use devices that are used for PPE that we don't actually know how effective that is, because we didn't invest in studying it ahead of time. So I think there are some lessons we can learn, and having more data, thinking about resilience, not making assumptions about the disposable items, and then also remembering, not to say that I don't think waste is important, it really is, but just remembering that, like, what's the big picture of sustainability in healthcare, and energy is definitely our biggest opportunity to make a difference. I don't mean to discount the concern about waste, but I get like a ton of questions about styrofoam cups, for example, which I don't love styrofoam cups, but they're a drop in the bucket when it comes to the healthcare's impact. But I think those are really good questions, and I hope that we take these learnings back. I know there are a lot of people in the Healthcare Without Harm Network who are thinking about how we can apply these lessons in the future.
Thank you. Claire?
Great. Thank you so much, Dr. Bole. That was an incredible presentation, and I love that you're helping us actually develop our vocabulary and kind of comfort with these concepts as we are medical learners going forth in the healthcare system. So I wanted to start out with a question that I actually had from one of your early slides, showing that kind of graphic of US energy usage in the healthcare sector compared to other countries.
Mm-hmm.
And I was trying to think of why in the United States, you know, our energy output is so much higher compared to other nations that are definitely more populous and also have fairly robust healthcare systems like China and India. I noticed our piece of the pie was so much greater. From your perspective, I know you've talked a lot about, you know, what our biggest challenges are, but can you compare between countries and perhaps what other health systems, whether it's their insurance scheme or coverage system, like why we are still so performing pretty poorly comparatively?
Yeah, I'm happy to, and I just will qualify by saying that some of what I'm about to say is a little bit speculative, so I don't have data for you on every point I'm about to make. But one thing I think there are a few points. We know that European hospitals use half as much energy per square foot than US hospitals. There are probably a lot of reasons for that, but I think that some of the same issues around like policy and kind of a collective consciousness too about climate action is different from country to country, and so all of our commercial buildings are more wasteful than a typical commercial building. So I think there's some of it is just about how we manage commercial space in terms of energy use. I think that we have a healthcare system that continues to incentivize like fee for service instead of keeping people well. I think we're seeing some transitions away from that, but not on a large enough scale. And so it's really interesting, you know, having been more involved with healthcare operations, there's a lot of incentive to go out and look for more revenue and order more tests. And we don't feel as healthcare providers that we're operating under those kinds of incentives. And I mean, I think it kind of makes us even bristle, like, no, I'm ordering tests for the right reasons. But the fact is, like, what are the kinds of facilities and the kinds of services our health systems want to invest in? We don't get paid to do a lot of the work that those of us in primary care know we need to do to keep people well. So I think some of it is about like a lack of incentive around efficiency in the way that we operate and the way that we care for people that contributes to that.
Got you. Thank you. And as a follow-up to that, a question from Sam here at Emory, kind of wondering if there have been any efforts underway to link carbon emissions by healthcare institutions to reimbursement plans. Is that something like kind of going one step further that you've heard of?
You know, I actually can't think of any great examples of that. I know there have been some efforts around community benefit reporting for healthcare institutions that are not for profit, are required community benefit reporting to build in climate action into it. And I feel like some of the better examples of that There's some really good examples like from Kaiser, from the Catholic health systems out west. I'm not aware of any incentives from payers, but I'd love to see that happen. It's a good idea.
All right, so this question is kind of a combination from a few different people, from KU, from Simona, and a few others, kind of talking about specifically what role as physicians and students and residents in the healthcare system, what are some easy items that these people in their daily work in the clinical setting can kind of bring up the pipeline to healthcare administrators, because some of those broader issues seem kind of intangible when you're kind of the person, on the ward, just looking at an example of a problem.
Yeah, I think it depends on I think there are a lot of contexts where you can make a real difference. Like at the bedside, I mean, where the red bags are located is something that you can do that in real time. If you're in the ED or the ICU or something, is there a giant open red bag right next to the bed and you have to walk 20 extra steps to go to a tiny regular trash can? Well, if that's the case, the busy nurse, the busy physician is just going to toss whatever she or he is holding into that big open bag. So that is something you can do in real time wherever you are. Like look in the red bags and be like, oh, it seems like a lot of what we're throwing away doesn't belong there. Maybe we could switch the position of these two containers or right size the container so that it's easy to make the right choice. It should never be harder to make the right choice. So that's an example of something that like I've done that and it works. So there are a lot of things at the bedside that you can do like that. I think that like the conversations about energy, waste management, and purchasing, they might seem out of reach, but they're not as out of reach as you might think. I promise you that I myself have just like looked up who the facilities director is at my hospital as a medical student and as a resident, just to ask them like, hey, it seems I don't see any, some of my first questions were kind of like, I don't see any recycling bins. And then I did ask like, what, do we have an energy plan? What's our Energy Star score? On nutrition, like if you notice that your cafeteria or your patient menus are not healthy, or they just don't seem like they could be better, like who's your head of nutrition services, and email that person. I think sometimes we underestimate how powerful our voices can be as students, residents, and faculty and physicians. Just by saying like, this issue is a health issue that matters to my patients, I'm wondering what's our plan for energy management. I want you to leave you with the impression that that's a very attainable conversation to have, even if you feel like you're stepping outside your lane. Just saying that you're a physician who knows that this affects your patient's health is a great way to start the conversation. But yes, there's a lot you can do right at the bedside, and waste management is a good example.
Thank you. And one more question that's also kind of a little bit of a combo. From Natalie and Ben, both here at Emory, kind of asking about if there's any curriculum at Case Western for medical students and residents to kind of get this in at the ground level, to make sure everyone's on the same page and aware of kind of what they can do. But also wondering if there's any committees that you have at Case Western of like students and other examples of people just kind of like having these conversations more regularly.
Yeah, I mean, a lot of the health systems in the healthcare the Healthcare Without Harm network have some commonalities in the kind of infrastructure that they have. So a lot of us will have like a sustainability committee, and then there'll be like subcommittees at different facilities. Like that's pretty common. Most hospitals and health systems love having physicians, students, and residents on those committees. Purchasing committees are another place where these conversations can happen. Design teams, when there's like a building committee, the disaster preparedness committee is another place where these conversations can happen. In terms of education for our students and residents, I mean, I endeavor to participate in advocacy education for our pediatric residents. And we have some people that are doing really great work on climate and health education for our medical students. But your point is well taken, that I think we could be doing a lot more to engage our own students in the health sector sustainability part of this work, because I hope that it feels like a really practical opportunity to make a difference. So I know that the Med Students for a Sustainable Future are really engaged in that work, and the Healthcare Without Harm Physician Network is trying to expand opportunities to educate our peers too.
Great. I think we're out of time, but thank you so much for answering all these questions. I know there are so many more we all have, but we really appreciate your time and hearing from you.
My pleasure.
Thank you. And if there are more questions, we can send them in a follow-up email to you and get them back to the students who have asked them and to everyone who's on this call. I just want to second your emphasis on, for the students, don't underestimate the power of persistence and energy. You may not feel like you have a lot of energy right now, but you guys bring that in abundance, and my experience. And I think that a lot of the changes we've been seeing around climate education have been driven by students. And I think the same is true for some of the sustainability changes in our healthcare setting too. So what Dr. Bole said, really take that to heart as you get back into your clinical rotations. You guys have an opportunity. Your voice does matter, and you can absolutely make a difference in these areas. So if you guys will all join me in thanking Dr. Bole, Aparna, that was wonderful. Thank you so much again for graciously sharing your time with us. And